Setting up a neonatal hearing screening program is really, it's a top, I mean, I've been given 20 minutes to speak, and anyone who has done the program will know that there's a lot of stuff which is there involved in setting up of a program. So basically, we just go back to why start a neonatal hearing screening program. Obviously, the first step is, the first reason is the magnitude of the problem. We should be having the 1991 disability census in Karnataka said that one child had a profound degree of hearing impairment for every 1,000. Now, according to the census, the people who conducted the census, they said they might have missed out a couple of children because it was a new field. But we are not talking of only children with profound hearing loss. We are talking about children who also have a moderate hearing loss and severe, and so therefore the figures are larger. So 5 to 7 per 1,000, and if you just convert it into for 1 billion population, the magnitude is really huge. And so we really have to do something to get the identify those children as fast as possible. And you just had a nice, two very good presentations about the importance of early identification, how the window of opportunity is so low because of the growth of the brain, and what can be done when children are identified so early, because it's so easy to talk to a baby. There's so many things you can talk about, and that being the condition, the intervention is going to be more effective when it is done in this period. So now, earlier there were a lot of issues. Should we conduct neonatal hearing screening? Isn't it traumatic for the mother? Won't the, so much anxiety, and are we going to be able to give the right thing? Maybe the mother will reject the child. All those issues were there, and even up to 2001, there's an article in Journal of American Medical Association which says that there's not a single good study which has compared, the follow-up. And anyway, the children would have been found. Children with profound loss are still identified, but recently there have been a lot of studies, huge studies, which have tested thousands and thousands of children, and there's so many ongoing programs which have been positive, and so the program efficacy is undoubted and therefore should be started. Now, before we start a program, anyone wants to start, it has so many issues come into the picture. Who is starting the program? Now, suppose I'm a private audiologist, I might want to start, or I'm a private doctor, ENT, or a pediatrician, anybody, I might want to start a program. So what I will think of will be different, or maybe it's the organization I work in, or maybe somebody is going to fund the program, so all those things have to be resolved. Because it depends, the whole protocol will change. If a private person is doing, how much involvement will be available from everyone might not be the same. But if it's an organization, there might be more support and it's more likely to be successful. Then the other problems come, what degree of loss is to be identified. Now if you're thinking of only severe to profound, maybe anyway they'll get identified by 8 months, age of suspicion. By 8 months the parents are feeling, maybe this baby has a problem. Should we use only a high-risk register, or we want to identify all degrees of loss, but identifying a mild degree of loss is of no use. So what degree of loss? And then after they identified, what arrangements are going to be made? We can't just identify and leave the children like that, the babies. So now, once those issues are explored, then there are 4 things that have to be remembered. You have to get involvement of everybody. They have to educate the person, or whatever organization is starting has to educate the people on the type and what has to be done, and the program has to be sustained, and after that treatment should be given, rehabilitation or treatment. Sustainability is a very important part. In Bangalore, when we conducted in St. John's Hospital, we helped to start that program. So then sometimes we would have holidays and the hospital did not have holidays, so it had to be sustained, and all our staff and students were all very supportive. They anyway went, whatever happened they went. So sustainability is very important. But when we first started in another hospital, a government hospital, it was very difficult, it was very far, we took at least 1.5 hours to go there and then to come back, and could test hardly 2-3 babies, so it could not be sustained. So when the place is selected, the sustainability has to be checked, and only then it has to be done. So now, to run a program, so many people have to be involved. Now, anywhere the program has to be started, there will be something called an ethical committee. So they will ask, will the baby, many of them are high-risk babies, will they be harmed in any way by giving sounds to their ears? And is it ethical? Will they get hurt? Because you might, if they're doing an ABR, you might want to scrub the skin. What are the chances of infection? So there will be an ethical committee which will look into it. And the hospital which is conducted will want to know the cost-benefit analysis. Now, costing means you have to cost all the man hours. Suppose I spend so many hours and I test only 3 children, that's of no use. So how many man and how many people are involved? Someone has to come get the baby there, someone has to test, the whole thing has to get reorganized. So what are the man hours involved? What is the cost of the instrument? How many babies you can test? All that has to be worked out. And then what kind of testing? Is it a single one-shot, do the OE? If they don't get a good response, repeat the test and stop at that, or is an ABR necessary? So again, who has to be tested is a thing, because if we do only OEs, we miss out people with auditory neuropathy, and are we going to test them also? So that has to be decided in conjunction with the hospital. So if maybe only, they might decide that only neonates from the NICU will have both the tests, the others we cannot manage. Why these numbers come up is because when we just did a survey, we found that in each of the government hospitals in Bangalore, 25 babies are born every day. And the number of professionals are so few that it is impossible. Every day someone would have to go test all those 25 babies, only in all the hospitals, which was not possible. So all the numbers are so huge that you have to make some choices and cut off a few and decide what. Then the other things, that is, when do you stop a test? Do you go on waiting for the test to continue, or till you get a response, or do you stop after so many minutes or seconds or whatever? So for those aspects, it is there are a lot of literature available which is better to read. Then what kind of screening should we do? OEs or ABR or both, as in the 2-stage thing? And I'm not talking about ASSR, because ASSR is still not accepted as a test of screening. There can be some false positives and negatives in ASSR. So still ABR is the best choice. And even in ABRs, should only clicks be used or should tone bursts be used? All those things also have to be decided. Okay, now suppose it's a TOE, then the criteria for pass can vary. Now some instruments say pass, fail, but they don't tell what kind of instructions. Now I've seen some bad things happening, that the baby has been passed saying that normal hearing. 2 months later the parents come and say he's not responding, and sure enough when the test ABR is done, then there's no response. The baby is not responding behaviorally, and that's because of just an equipment which says pass, fail. So when the equipment has to be bought, don't trust which gives you the result. You should know where, what is it based on. Is it saying pass based on 1, 2, 3, 4, so many bands of frequencies, or is it only on 2 bands of frequencies? So those things you have to check. So before you buy the equipment, you have to see what kind of equipment you want. You want TOE, TPOE, you want who is going to use it. Now, yeah, because you get those tiny ones, and then someone drops it, that's the end of it. It cannot be repaired. So if only one person is going to handle it, they're going to last. But suppose, let's say 5, 6 people are handling it, and some may be very young people who are not used to it, they might drop it, and that's the end, no repair, nothing. The repair is as the same as the cost of the equipment. Then what kind of the after sales service? Now all of you probably, I'm sure you all look at it in any equipment, but many many vendors who sell the equipment, they don't give upgrades free. So some people give upgrades free. And then some have problems, so it's better to do a good survey with other institutions and see which is easy to use and which give robust, which is quick. So you might want to have a small one like this with accessories which come like a box. So it looks very neat and nice, but it depends on who is the user. If it's a teaching institution, this is not to be recommended at all, because definitely someone will drop it. Okay. Then other conditions are hygiene and safety. When so many babies are tested in the NICU, there can be cross-infection. So all the materials should be used as disposable or should be sterilized in a very effective way. That includes the test personnel. They should wash hands after each baby, and it should be still comfortable for the baby. The hands should not be cold and all. And then where are the electrodes going to be placed? Are they going to be placed on the fontanelle? I mean, they should not be, but who is going to be the person who they should know very well? And what is the test efficiency? That also has to be decided. So if we use large electrodes, the efficiency is better. In this picture you can see the electrodes are clearly, you get those disposable ones which have a large surface area, so they are better. You get impedance faster and the test is faster. So ideally the aim should be within a minute you should get all the response. ABR screening, if you do at say 2 levels, you should get at the lowest level with minimal noise. So now once these issues are decided, the doctors and all the people involved, the nursing staff, the billing personnel, support staff, everybody has to be educated. If it is not educated, they don't know what is going on, they will not support. And when they know, when the whole body is involved, they give a lot of good ideas which can be used. In St. John's, the support was so good that whenever we went, Dr. Ramesh was involved in that. All the children would come, all the babies would come one by one. Everything would be, all the data would be recorded, everything would be, it was so quick, we could test at least 10 babies in each visit. But it would not be the case in all the hospitals. So now, for the people to work well, the roles have to be clearly defined. And they might, the time to test will be decided by them because of the way the hospital works. All those things have to be decided when, and so in the beginning it's better to have a few dry runs. If there is a pilot project, you know where things can go wrong. If there is some interpersonal rivalry or some problems, that is very difficult to sort out. So it's better to stop problems before they start, better to have weekly or monthly review meetings and see what is going wrong. And most of the people are overworked, so it is a pain for them to do an extra work. And it is a pain to come for a meeting. Everything is a pain, but once it starts going, it will get much easier. And other things that anyone who starts a program should know: equipment malfunctions. Now, any audiologist will know that you have to treat equipment like with really tender, loving care. It comes off very fast. One probe can be dropped, some small things, and that's the end of the equipment. Or wax can get, vernix can get stuck in the probe tip. Good enough. Or the way the probe is inserted, the baby's ear can get blocked, and all sorts of things can happen. So you have to be careful with the equipment and keep things in other options in position. So suppose the equipment stops working, can't be repaired, then you need to have other mechanisms to continue the test. So maybe OE is not working, okay, then ABI, some kind of protocol should be there, or at least HRR. Good space is required for testing the babies. If you have a quiet place, testing time is reduced because it becomes, the noise is reduced. Noise, I don't mean just the general noise in an NICU or in any other place. Even electrical noise. Electrical noise can cause very bad responses in ABR, and if it is in a separate place, it is better. So sometimes parents get very irritated. If you knew it is so noisy, why did you test the baby here? They'll ask such things. So better in the beginning only keep a good place and educate the parents that okay, today we couldn't test because of this. But then as far as possible, all those things should be reduced. and have a good data entry so that all the data is clearly and well written. Always you need for a follow-up. See, now this is a good place. You have a separate place where the baby is in a crib for ABR, and this is for an OE. And if it is, if they come, this is in the NICU, but if it is in a well baby center, then the baby can just sit on the, can be, swaddled and put on the lap, put in the lap. Either the nurse holds the baby or the parent, depending on what kind of setup it is. All babies should be tested, followed up with a behavioral test, because that is a true test of, is the program good or not. If they pass ABR and all, and but then later, if you think they pass the ABR, but then afterwards you find that they actually have a hearing loss, there is no way of knowing it unless you do a behavioral follow-up. And this will take time, so that also would have to be decided. Should we test all or random or all NICU babies? And at such times, a language test also is a very good thing, because if the baby is acquiring language, knows his or her name, understands a lot of stuff, that also gives a good indication of what is the hearing loss after, to monitor. And parents have to be educated so that they will also report if they are moving away, they will keep an eye on the child and see what is happening. So again, the other issues come. You said the baby passed. Now why he's failed? All those. So the test protocols have to be verified. After at least 2 months, you have to verify, check, and come back, monitor the baby, especially the high-risk babies. Another thing is you have to be take care while testing. Sometimes mothers are there and they feel very bad. For the person who is testing the baby, it's just another statistic, but it should not. They should take care and be concerned about the baby, show that they care, and they should also be sensitive to parents' anxiety, because parents do get extremely anxious and tend to bug the people who are testing, tell me what happened and this kind of thing, and they're truly anxious. So you should reassure them and be careful, sensitive to them. Thank you for your patience.